Hello everybody. So today we are going to discuss the WHO recommendations on intrapartum care for a positive birth experience. So we will discuss the various stages of labor, the definitions of it, and what are the recommendations given by WHO to manage a lady who is in labor in her different stages. We will also discuss newborn care during and after labor. So let's get started. So, the first and the most important component of labor that WHO gives as a recommendation is respectful maternity care. Now, whenever I was going through the guidelines, I've seen supportive maternity care, respectful maternity care. These have been used in various contexts and number of times. That means WHO is very, very keen to introduce respectful maternity care to the labor wards so that the lady who is in labor, she's dealt with dignity, she's not mistreated, she's not mishandled, she's talked politely, and she gets the exact right treatment in her privacy. So respectful maternity care is an important part of WHO labor management. Now, renal cell carcinoma, RCCC. These four components are to be followed in every stage of labor. What I'm trying to say is, these are the four components which all the stages of labor a person who is handling labor should keep in his or her mind. So, respectful maternity care we've already discussed. Apart from that, we have communication. Effective communication with the mother is very, very important to tell her what is being done to her, what is her dilatation, how is the fetal heart, how is she progressing, how much time will she take in the labor. These are the things which have to be communicated to her routinely during each stage of labor as a part of management of the WHO guidelines. Next, we have a companion. Companionship is important in labor. That means a companion of a choice should be given to the mother to be with her during the entire process of labor and later, so that she can address to her issues, she can discuss and understand the issues during labor when she's in enormous pain, and that is why we always need to have somebody as a companion during the various stages of labor. Last but not the least, continuity is important. Now, continuity of labor care is something which is done in areas where it's possible. Like, for example, there are areas where you have midwives who can take care of the mother before, during labor, and also after labor about whatever, if anything goes wrong, the lady can be at least brought to the healthcare facilities, or her issues can be addressed by the midwives. So, in those contexts, in those areas where this facility is available, continuity of care is very, very essential. So, these are the four. The mnemonic goes like renal cell carcinoma and an extra C. So, that is what the four components which are to be covered in all the stages of labor. Now we come on to the various stages of labor. The first stage of labor, this is the portion where the lady comes in latent stage, then she gets into active stage, she gets her pain, she gets her cervical effacement, dilatation, so many things they happen during the first stage of labor. So we will discuss about its management. Now, as you can see, a very cute, beautiful lady has come to the labor ward during the first stage of her labor. Now, this picture, if we can remember it, it will help us remember all the things which are to be done, and I'll go step by step so that nothing is missed. So, the first stage of labor In case of primigravidas, first of all, the definition goes it is on an average, it lasts for 12 hours, but definitely it can last for more than 12 hours in some primies. And in those cases, when we discuss about labor care guide, which is nothing but a better version of WHO partogram, so there you will see even the chart, it mentions 12 hours. Sometimes if the lady oversees that time, we have to put in another chart to plot all the findings of her labor. So anyways, the first stage of labor in a priming patient is 12 hours, and multigravida it is usually 10 hours. Okay. And if we talk about the components of the first stage, it is in a latent phase as well as in an active phase. Now, what is a latent phase? Latent phase of labor means the patient is in labor for sure. That means she's having painful uterine progressive contractions, there is cervical effacement and dilatation, but it is less than 5 centimeters of cervical dilatation. Till that time, our lady, this beautiful lady, she is in the latent stage of labor. Once she's more than 5 centimeters onwards, she comes into active labor. Both these components, latent as well as active stage of labor, are included in the first stage of labor. Okay, so this is the definition of latent active stage and the duration it covers as per WHO recommendations. Now, if we talk about the management recommendations of a lady who walks into the labor room in the first stage of labor, this side covers the recommendations and this side covers what are not recommended. Now, especially for students appearing for examinations, you can have a lot of questions on the recommendations and what is not recommended. So it's extremely important for you to just understand, because this is a very, very simple thing, especially for people who've worked in labor rooms. They know very well how to go about this. But just a little bit of brushing up as in what is exactly recommended is important. Okay, so first and foremost, we come from top to bottom to get an idea about what is to be done and not forget any point. Now, one thing which I would want to say is there is a thought about it is not a very clear recommendation, but definitely WHO says that women who have come in active stage of labor, you can admit them, but those who have come a little before that, admission can be delayed. Now, this recommendation is not absolute. It is though recommended to admit women in active labor only, especially low risk healthy women. But then again, from case to case, you have to assess the condition of the woman and admit accordingly. But yes, the recommendation does say for low risk and healthy pregnant women, uncomplicated pregnant women, they are usually admitted in the active stage of labor, that is from 5 centimeters onward. Now, she came to the labor room, she was admitted, and she is over to you. Okay, now first and foremost, if you can see, this lady is not very happy. She is crying because she is in labor. Not a single woman in my life and so many years of experience have I seen who's come to the labor room smiling. Okay, so the cry in itself says that she's in pain, which needs to be managed. Now, pain management is extremely important component of labor, because when we discuss about the uh, abnormal labors, we'll see how pain management can also help in progress of labor at times when there is a issue with progress in some of the abnormalities. So pain management, what I'm trying to impress upon, is an extremely important component of first stage labor management. And how do we manage the pain? It is up to the mother's choice. If she is a mother like me who is very fond of music and can be with it in any stage of her life, then you can give her music, you can give her relaxation. If she wants some sort of meditation or whatever, mindfulness, you can give her If she's keen for epidural, definitely communication is again a part of the management. You explain it to her what is communication of epidural. She understands. You can give her epidural. If she wants, like, no, I don't want to pay for the epidural or whatsoever, or I just want IV. So you give her IV pain relief. You can give her fentanyl. You can give her dimorphine. You can give her pethidine, or if she's not willing for any of these, you can give her a warm pack, or you can give her massage, whatever she feels like, whatever she finds is appropriate for her. You can give her all the options and let her choose. Okay, so the first and most important, one of the most important part is done, which is pain. Then we have her hydration. For uncomplicated women who are in labor, healthy pregnancies, hydration is oral hydration. You can just allow her to drink as much fluids as she wants, and that is going to be enough. There is no routine recommendation of IV hydration. Okay, so you give her oral fluid, she'll drink it up and she'll be all right. Okay, then coming on a little down below, coming to the monitoring. Now you've taken care of the mother, her hydration and her pain. Most of the time, if these two things are addressed to, she's going to be all right. Okay, now coming on to the baby. Okay, now uh, we have a general thought that continuous CTG monitoring is going to be of a bigger help to the mother and baby. WHO recommends against it. WHO says intermittent fetal heart rate auscultation with a stethoscope or a can Doppler ultrasound is enough, and you don't need to go into a CTG continuously. So continuous CTG comes under the not recommended zone, and intermittent, when we read about the labor care guide, we'll come to know that 30 minutes is the time for fetal heart rate auscultation in the first stage of labor. So every 30 minutes you just got to put your steth for 1 minute, see if everything is all right. That is all you have to do. Okay, now coming on to, this is the baby. Now the progress of labor. To assess the progress of labor, a PV examination is what we generally do. Anybody who's worked in the labor is very used to this. So PV is to be done 4-hourly. 4-hourly PV is enough in the first stage of labor. Again, if there is something happening, if there's some sort of an event in which a PV can help the mother, like for example, if there was a rupture of membrane, you do a PV and you see. So at those points of time, you can proceed. But the general recommendation, if everything's going fine, is PV every 4 hours. Okay. So now not recommended. Now we have this thing, just shave the perineum. Everything chak. That is not recommended by WHO. Perineal shaving routinely not recommended. Continuous CTG, I've told already, not recommended. Enema. No need for an enema. Everything, what I could make out of this is they've kept it bare minimum. So routine enema again is not recommended. And if you go through the guidelines, there's so many things given, uh, you know, uh, oxytocin or painkillers or whatever, just to shorten the first stage of labor. Nothing of that sort is recommended. So if you have a question where is oxytocin or ARM or painkillers to shorten the first stage of labor, just to shorten the first stage of labor, these are not recommended. These are recommended augmentation, and everything is recommended only and only when there is an indication, and not to shorten the first stage of labor. That is all we have about the first stage done. Now we come about the second stage of labor. Now this is the most beautiful part for the baby and for the obstetrician, because you see the baby coming out, but it's the worst part for the mother. So you can see she's crying all the more profusely. I can imagine, because I have been in this stage for quite some time. Anyways, so now if we talk about the duration, it is 3 hours for primary and 2 hours for multi. This is the general recommendation for the duration of first for the duration of second stage of labor, 32, 3 and 2. Okay. Now, what is the second stage? Full dilatation of cervix and the birth of the baby. That's it. You cut the cord. That's the second stage of labor. Okay. Now, what is the most important part, the special part of this stage is the maternal push. Okay. The expulsive efforts of the mother, that is an important component of the second stage of labor. You can just imagine a mother, she came into labor, she was less than, she was in whichever active or latent stage. Now you gave her fluids, you gave her pain relief, and you monitored the fetal heart rate, you assessed the PV. Now she has become full dilated, now she's pushing. So when she's pushing, she has to follow her pushing urge. That is all you have to remember as per the recommendation. Say, so just let her feel the push urge and do it. Now for epidural, there was a recommendation that you can delay the push for 1 to 2 hours in areas where there is proper, there has been a proper study about the whenever there is a delay in the push, how the baby goes, if there has been any perinatal asphyxia, how was the mother, how was the baby. If there is a context where these things have been taken into consideration, if there's an area where these things have been properly considered and studied, then maybe you can, and everything went well, then maybe 1 to 2 hours of delay in the push can be done with an epidural. But otherwise, generally it is recommended to follow the urge of the mother. Okay. Even in epidural, she does have that urge, if even though it's not painful, so you can follow that urge. Okay. Most of the women, they have the urge. Now, position is important. I forgot to mention the position even in the first stage. We always prefer an upright position, but you can give her the position of her choice. Just keep in mind that supine position is not desired, because as the mother is supine, the IVC gets compressed by the uterus and the baby. So upright position is preferred, but you can, in the second stage preferably, you can give her the position of the choice of the mother. Okay. So now we come down below. Her pain we have already managed. Poor lady, the cervix is full dilated and she's given this thing of a choice. Second stage fetal heart rate monitoring happens every 5 minutes. But in the partogram, there is no 5 minutes section in the latest labor care guide. So you have to plot it every 15 minutes with the most significant value in the last 15 minutes. We'll discuss that in details with the labor care guide. Okay. So then we have 3 recommendations. Perineal care. It's very, very comforting for the mother if you give her a little bit of warm compress, perineal massage, perineal guarding, so that there is not much tear during the delivery. It's very, very helpful for the mother, because in that pain, if you could do just anything to help her out, that's a very, very positive experience for the mother. Okay, she'll never forget the face of the doctor all her life, I can assure you that. Okay. Now, not recommended is fundal pressure. We have this, especially when you're very young and you're working in a labor room, you just want to deliver the baby, and you're like, if baby's not coming out, let us push the fundus and push the baby out. Don't do it. Routine fundal pressure and routine episiotomy. Again, there is still a lot of places they're practicing routine episiotomy in primi gravidas. It's not recommended. Just give it when it's needed, and not routinely in all primates. So please keep that in mind. This is again only these 2 points that you have to remember in the second stage of labor, and the picture says it all. So if you can just remember the picture, I think, and have a little bit of clinical idea, a lady is there, she's in second stage, what all you can do for her. Anybody who's been in labor or has seen somebody in labor can get it easily. Okay. Now the major part is done. Baby out, mother fine. Now finally she's happy. Now third stage of labor, we've seen in especially Bollywood movies, the baby is okay, but the mother is still in danger. Okay, this is the situation where the baby is okay and the mother may bleed. with a postpartum hemorrhage. PPH is still a very, very important cause of maternal death. It is real, okay, and this is something we can easily manage by our skills most of the times, if not always. So, third stage is a very, very important stage of labor, which is the removal of the placenta and the afterbirth. Now, active management of third stage of labor. This is something which I think everybody who has been in the labor room or has been an obstetrician, you have it in your blood now. So, active management is through oxytocin, 10 units of oxytocin. You can give it IV, you can give it IM, whichever way you feel like. Or if you don't have oxytocin in the labor room, you can give Mithargin, you can give a combination of oxytocin and ergometrin, or you can give oral misoprostol 600 microgram. Okay, just put in the tablet, pop it in, tell her to just have it with water, and it is done. So, recommended most importantly is oxytocin. If not available, meso, methyl, ergometrin, these can also be used. So, active management done. Now, delayed cord clamping, it's a very good concept because when I was doing my when I was operating on my patients or delivering them, I always used to feel that it used to be helpful. So, if you want to save on those little bit extra blood losses during the third stage, then it actually helps. So, even my personal recommendation and WHO's recommendation definitely is delaying cord clamping by around 1 minute. Okay, so baby is delivered. Sorry, cord clamping is a part of the third stage. Okay, cord clamping is a part of the third stage. Baby comes out and the second stage is over. Cord clamping and everything comes in the third stage. We have to keep that in mind. Okay. Now, so delay the cord clamping by 1 minute to prevent unnecessary blood loss. And for areas where you have a skilled birth attendant, controlled cord traction for a controlled delivery of the placenta is extremely beneficial. So again, CCT is recommended, controlled cord traction is recommended where you have a skilled birth attendant. Okay, what is not recommended is a sustained massage to manage the third stage. That's not recommended. Okay, but routinely for non-complicated, normal, healthy pregnancy, sustained fetal massage is not recommended. So that is all about the third stage of labor. Now coming on to the finally the next 24 hours after the lady has delivered. These 24 hours are very, very important for the mother and the baby. Why for the baby? Now, baby, generally there are three values which I think the recommendation says which is important. The first hour after the delivery is important, and immediately after the delivery. Why is it so important? We have to discuss. Now, the baby was born, there is a reflex to just suck the nose. Baby is crying, baby is breathing, still we have that reflex. Don't do it. It's not recommended to do routine suction for babies who are healthy, crying, and they are fit and fine. Okay. Now, first hour after the baby has delivered, the first thing and the most important thing that we have to do is give it over to the mother. She'll hug the baby, they'll be together for the first 1 hour. It will initiate breastfeeding and prevent hypothermia in the baby. Baby has suddenly come out of something. There's so much of change in environments. First 1 hour, they should just be stuck to each other. Okay. So mother and baby together for the first 1 hour. After 1 hour, you give the baby vitamin K 1 milligrams IM injection. And 6 hours, in fact 24 hours is the time till which you have to delay bathing of the baby. But if for religious purposes, some people are very, very stringent about their religious purposes, for those people you have to say that at least for 6 hours you cannot bathe the baby. Okay, so 6 hours for stringent, extremely religious patients, and 24 hours is the general recommendation for bathing of a cutie baby. Okay, So that is about the newborn care just after delivery. Now for the mom just after she delivers, there's so much you have to do about her because the uterus should be contracted, the bleeding should have settled, there should be everything all right with her. So just after she has delivered, you have to see the vitals, temperature, pulse, BP. Then you go from above, you see the vitals from the axillary, the temperature, pulse, BP. Then you go down, assess the tone of the uterus if it's contracted. For all obstetricians or people who worked in the labor room, they know what I'm talking about. Just feel if the uterus is hard enough and it's not like totally relaxed, because atonic uterus will bleed. So we want the uterus to be well contracted. So feel the contraction, tonus assessment is recommended. Okay. Then we have assessed the fundal height. If the fundal height has settled, that again gives an indication of a good contraction. Then you come a little down, 6 hours. No, first let us finish just after birth. PV bleeding, you have to assess if there is not much of PV bleeding, because it's extremely, extremely important that especially during the first 1 hour